Welcome to tonight's webinar, co-hosted by APMA and PICA. I am Dr. Dyane Tower, APMA Director of Clinical Affairs, and I'll be your moderator this evening. This live webinar will be recorded and is provided complimentary exclusively for APMA members and PICA policyholders. Please note this webinar will not be for continuing education credit or be used for risk management discount. During tonight's webinar, we will hear from our panelists on several topics related to the provision of care and treatment post-COVID-19, including operations, communications, infection control, and more. Our panelists this evening are Dr. David Freedman, Dr. Krupa Patel, and Ms. Linda McSmith. Dr. Freedman has been in practice for 34 years and in group practice since 2011. His group has 84 podiatrists and roughly 50 offices in Pennsylvania, Maryland, DC, Virginia, and North Carolina. It is known as Foot and Ankle Specialists of the Mid-Atlantic. He serves as Vice President and Chief Compliance Auditor for the group. He has been actively involved in solutions for his practice with COVID-19. Dr. Patel has been in private practice in New Jersey since 2011. She serves as the managing partner for her 4-office, 6-doctor practice in North Jersey. Dr. Patel is a previous past president of the New Jersey Podiatric Medical Society, a member of the APMA House of Delegates, and a faculty attending at the Atlantic Health System Residency Program. Ms. Linda McSmith is a nurse and certified healthcare risk manager, and she is the manager of risk management for PICA. She has been a registered nurse for over 30 years and a risk manager for more than 25 years. Linda is responsible for managing PICA's risk management program, coordinating risk management, consultative and educational services to PICA policyholders, developing risk management resources, and authoring risk management articles. Our legal notice and disclaimer for this evening: this information contained in this presentation does not establish a standard of care, nor does it constitute legal advice. The information is for general informational purposes only and is prepared from a risk management perspective to aid in reducing professional liability exposure. Please review this presentation for applicability to your specific organization. You are encouraged to consult with your personal attorney for legal advice. Specific legal requirements may vary from state to state. We will have time for questions this evening during the webinar. So if you do have questions throughout, please use the Q&A function in your Zoom toolbar. We will address as many questions as we can during our allotted time. I'll hand it over to our first panelist, Dr. Freedman.
Thanks, Dr. Tower. Thank you everyone for joining us this evening. The first topic we're going to discuss tonight is about your operations for your practice and things that you may or may not have thought of as you open your practice. It's very critical that you look at all your insurance coverages that you have for your practice. Those things may not only include malpractice coverage, but also your general liability coverage. You want to make sure that everything's in force that covers you for anything from a slip and fall to any type of issue that can occur within the practice as you, again, re-engage patients and your staff working with you. The readiness part of your practice includes different parts, includes your staff, includes your third-party vendors, and you need to make sure that you're looking at everything as the staff gets ready. Things that are important to you to make sure they're being kept safe. Very important thing for staff includes masks. What kind of facial coverings are you offering them, and how will you help them be kept safe? Are you going to offer them eye protection, or are you going to offer some type of shielding at the front desk so that patients hopefully don't cough or sneeze on an employee that could give them potentially COVID? And how are you using your staff to facilitate and make sure that people are entering the office appropriately? The other thing to look at here tonight is also how we evaluate and update contracts. It is important to make sure that nothing is affected by your COVID-19. Certainly all your payers that you've been dealing with had different options for you to do extra office visits while you're doing telehealth during this past 2.5 months. But you have to look and make sure that there's no changes in payer contracts or the things that have to be done with payer contracts at this point in time. And you got to look at your initial response and how you're reviewing things in your practice. Are you able to get things up and running without a hitch? Are you able to just open the door? Did you order a thermal thermometer for the forehead for patients so that you can test patients? Can you also test your employees as they start their workday? Things like that become important. And you have to understand that there's potentially going to be a second wave in the fall or later on this year sometime when the typical flu season begins, when there's going to be people more in contact with each other, when people let their guard down, when people be not socially distancing as much as they were initially like they have been now. These are all potential issues that could cause a major second wave of COVID-19 as we progress through the summer into the fall. Telehealth. This has become very important in practice, and I was surprised to see some surveys where almost 45% of our colleagues are not using telehealth. At this point in time in our careers, it's very critical that we learn different ways to communicate with our patients. And during the health emergency, we were given the opportunity to do telehealth, and they're reimbursing you at the same level for telehealth that you would be for office visits. And the key thing is just figuring out what's best for your practice. You have to pay attention to obviously all your state and federal laws and regulations with this, but telehealth services were giving us the opportunity to use various tools to do telehealth. Now, HIPAA has not been absolved by the telehealth and by the emergency, but you still have to try to keep your audio and video format in a secure possible manner as you can. I've used one type for my practice, and at times when you try to use one of the secure methods, the patient can't do it. They have a phone that's not adequate to do that. They may only be able to use FaceTime or something else. Well, during the emergency, they're allowed to use Google Faces or FaceTime or one of the options that are there. So you can use different ways to do audio and video with a patient and do your telehealth visit. Another thing that's important with telehealth is to understand that you can't palpate things, you can't touch things. And in audits that we've seen with medical records already, we've been able to see that doctors are saying they're palpating and touching and doing things. The fact of the matter is, in a telehealth visit, the patient can touch things, the patient can show you things. And that's what the examination is all about in a telehealth setting. But the great thing about telehealth is it allows you to see the patient in a one-to-one setting, just like you would in the office. You're able to talk to them, they're able to describe their problem, and you can get a good idea of some of the medical conditions that they may have that can be treated via telehealth. It's very important that you also set up possibly a template within your electronic health record, because it's very critical that the form flows. Things that are necessary are for example, is it an audio video type of telehealth visit? What is the medium that you're using? Is it, for example, like FaceTime or Doxy.me or whatever it is? And then you should also say, where's the patient residing? Are they in their home? And where are you? Are you in your office? And then another thing that becomes important is a consent by the patient. It's important because I know through PICA drafted a consent that's written, but you also may want to have a verbal consent that you get the patient to give you, and you document that the patient gave you verbal consent based on the health emergency, and they're allowing you to do telehealth with them in your visit. So you have a verbal consent in your medical record for you at that time. And of course, like any other medical record, it's critical that you have a great, robust discussion in your plan. So your medical decision-making is very critical, because in this telehealth emergency, with the emergency, you're allowed to bill for your office visits based on either medical decision-making or time. Now, you may only spend 5 to 7 minutes with a patient, but you may end up doing a lot of information that's provided with the patient. And what we instituted and what we recommended is we then go ahead and do a paragraph about that session with the patient and turn around and mail it to them, so they have some type of record about a reference for the visit, for that telehealth visit. So telehealth can be a very important thing with your practice, and you have to decide if you want to do it. You don't have to do it every day. You can do it at different parts of the day. You can assign a certain time, like maybe at lunchtime or maybe at the end of your day when you're done doing other tasks with your practice. But you certainly still can do telehealth even at this point in time and hopefully maybe in the future. Right now, we're not sure if it's going to be a thing that will be available forever, but right now during the emergency, it's still allowed. And with Medicare, we know it's allowed all the way into September. Under employees and HR human resources, it is very important that our employees feel safe about returning back to work in this COVID-19 health emergency time period. So it's very important that we establish some type of screening process for that. What we do with all employees is everyone has to sign in each day at this point in time, and they have to get a temperature check when they walk in. Everyone must go right to the nearest sink, wash their hands. Everyone wears masks when they enter the office. They also have the ability to wear goggles to protect their eyes, because there's been some discussion about the possibility that the COVID virus can be spread through aerosol by not only breathing, but also through the eyes. Some people like to use plastic shields at the front desk and whatnot, again, to protect their employees. That's up to you. The most important thing is masks and probably eye protection are the important thing. For the ability to provide PPE for the office, you just got to make sure you have gowns that if you do have a patient that is suspected of having COVID, but yet they have a foot emergency or some type of foot problem that has to be treated, you have to be prepared for this. This is nothing unlike we had back in the 80s or so with HIV and AIDS. You had to be prepared, you had to have gloves, you had to have gowns. So this is just another time and point in time in medicine where you just have to have the PPE available for staff if they need it. You try to have the staff check each patient as well as they come in, so they're not being exposed to people potentially that have COVID-19. So you got to talk to everyone. You got to talk to your staff and make sure they feel comfortable. I think if they see you comfortable, then they will be comfortable. So you wear the mask, you wear eye shield protection, you wear a gown if you have to for certain patients. They get to see and feel more relaxed knowing that you as the physician, you're the doctor that's in charge of the practice, that you're taking that important step to make them feel very comfortable. I think it's very important for everyone to understand that, so if they work, that they're not going home and having problems, with family. I know that some people have children that currently have been in school and doing Zoom school meetings. So you have to work around your your employee schedules to help with their children, to make sure that they get to school through their Zoom meetings, and that the parents can also then work for you when you can juggle a schedule around it. That has to happen at this point in time. The last topic here is about unemployment pay. I'm sure you're all aware that during the pandemic, you were able to furlough or employees and try to keep them a plan to come back. And obviously, once you come back to get them working, in my case, in our practice, we kept everyone working. We wanted not to furlough anyone, so I know some people have. In our case, we didn't. We wanted to keep everyone at least getting paid. So what we did is we actually reduced our schedule, and obviously like everyone else, and then paid them full time though during that reduced schedule period, because we wanted everyone to be ready to come back full time without any interruption. And that's what we were able to do for the vast majority of our employees, because I thought it was important that we have a smooth transition throughout this time period. And that's what we've been able to do through this point in time. Next thing is here on HR is just staying active, making sure that your license, your registrations, your certifications don't go out. Things like Medicare recertifications occur. They're still happening. I just had mine, for example, happen in the last couple of weeks. You just have to make sure that you don't let anything lapse. Your controlled dangerous substance licenses, your state licenses, whatever is necessary, please make sure that you don't let anything lapse. Double check websites to make sure everything is up to date. And you should have a human resources process about hiring new employees, because you have to explain to new employees how your office functions and how you protect them as well as any of the existing employees. There certainly should be some type of handbook that you have that you would use during this time and any time to make sure everyone is staying as safe as possible. And the last part here about thanking them and having meetings, it's very critical that you have very frequent meetings, because they have to understand what's going on, because the information that's coming to us is coming to us so quickly. It changes sometimes on a daily basis. So it's very important that as things change, that we give them the information that we have at our hands to show them that you're in charge, that you understand what's going on, you're keeping them safe as you can, You're going to thank them for being there. You're going to praise them in front of patients. You're going to show the patients that you appreciate your employees. It's very important that everyone sees, both patients and employees, show that you as a leader of the practice, the captain of the ship, that you really appreciate what they're doing for you and your practice. Now I'm going to turn it over to Dr. Krupa Patel.
Thanks, Dr. Freedman. So I'm going to talk about some communication issues that may occur at the practice in the post-COVID era. Some of the first things that we can do is update our patient portals, our websites, use blast emails and other communication methods to contact our patients. You know, unfortunately for us in New Jersey, we were hit pretty hard with the COVID pandemic early in March. And it was like a light switch where our office went from being fully functional to almost 10% capacity. One of the things we relied on was our website. We updated it almost immediately to reflect that we were only seeing emergency or post-operative patients or patients with infections. We also changed our hours and had that reflect on the website. For those of you who do use websites or online booking, it was one of the things we suspended pretty early, just to be able to properly triage patients or interview them before they were coming in for some non-acute issue. As things have sort of moved into the phase 2 era in New Jersey, we've also updated our website of the same to reflect that we are seeing patients, but we do have a strict COVID policy where patients will be asked to wear a mask, where we will be taking temperatures, and requesting that people come pretty much alone unless they absolutely need a caretaker or if they're a minor or a child who's coming in with a parent. You know, some of the things we always have to consider, you know, changing our normal operating hours to make sure that we can go back to the volumes of patients that we were seeing. You know, to go from being double and triple booked to now having to space patients out, it's something that we definitely have to consider. In our office, post-COVID, we have set up what looks like basically a football playbook where patients enter, what rooms they go into, arrows to kind of direct them out to the exit door only, to really minimize any cross-contamination or any crowding in our waiting rooms. One of the simple things we did is we just removed waiting room chairs. Instead of blocking them off where patients would just take off the piece of paper, we just took the chairs out of the room. Our waiting room, which used to have 12 seats, has 3 now in order to keep people 6 feet apart. We also put really easily seen, easily read signs on the front door that reflect our policy. So face masks, 1 person at a time, wait in your car. If you see someone in the waiting room, wait in your car, give us a call, and then we can call the patient in to go directly into the exam room. The way we've set it up at this point, we're able to see 1 patient every 15 minutes, but we also have 4 rooms in the office so that that can be done. One of the things that we should definitely consider besides updating our websites is, you know, utilizing our EMR if there is an email system where you can send blast emails to all your patients. You know, some of the things that are coming up now is that patients are actually fearful of going to doctors' offices or hospitals. And in order to sort of, you know, quelch that fear, we can let them know what we're doing. You know, we're making sure we're following these protocols. We have face masks, we're all wearing PPE. We have cleaning protocols that are in place. We have our new COVID protocol for our office. And patients are feeling better now that they're seeing that, you know, everybody's taking a part in making sure that this pandemic sort of calms down in these high and hit areas. You can go to the next slide. You know, if you did unfortunately have to close your office after the PHE, the public health emergency, started, you know, one of the first things we recommend is that you go back and make sure all the labs and test results or MRIs or anything that was ordered pre-COVID, that you followed up on those results and spoken to the respective patients. We are, like I said, we post signage in the appropriate languages at the front of the office to basically notify patients that if they have any respiratory symptoms, if they have a cough or a fever, they should absolutely notify our staff before entering the office. We found the signage directly on the CDC website, but there are links on both the PICA homepage as well as the APMA website. Those websites particularly have been quite helpful, particularly the checklist that PICA provided on reopening. It just kind of gives you a roadmap as to what things you have to be mindful of. So if you do get a chance after this webinar, just check that out for sure. We definitely, in our appointment reminders, we are making sure not only to tell the patient that they have to wear a face covering, but also what to do when they arrive for the appointment. Most patients are basically waiting in their cars until we call them to say that it's safe to come in. If our parking lot faces our waiting room, so you can see if someone's in there. So that does make things a little bit easier. In one office, in our other offices, that's not the case. So patients are waiting and they're pretty good about it. I mean, no one really wants to be exposed to more people than they need to be, especially in an area like ours that was pretty hard hit by this virus. One of the questions that we received was if there was a patient who called to make an appointment, but they said, they told your staff that they tested positive for COVID. So for us, our policy is basically to assume that everybody's positive for COVID. If a patient is confirmed COVID positive, we have trained our staff to have that patient reschedule for 2 weeks out, or when they're fever-free for more than 3 days. Now there's this question, what if that patient has some sort of limb or life-threatening issue that they must be seen, or they're, have an infection? Our protocol is to schedule that patient for the last appointment of the day, have them wait in the car, come directly into an appointment room. The doctor, we have, face shields, we have N95s as well as gowns. It's very minimal exposure to the medical assistant or the front desk. We do a contactless check-in, basically where we check them in on our end on the EMR side. If there is a copay or something to be paid, we have them pay that on their portal, just so that they don't have to interact with our front desk. We see the patient. Once they're done, we spray that room down and let it air out overnight with any of the EPA approved cleaners like Cavicide, Lysol, Clorox, or any of the things that you normally use in your offices. Next slide. As far as documentation, we are, I think Dr. Freedman mentioned documenting telehealth visits, particularly regarding the pandemic, the circumstances, why you're seeing this patient, and what was your rationale as to either doing telehealth or bringing them in physically to your office. Early on in this, during the pandemic, we were just seeing emergencies, but I would include a line in our assessment that despite the public health emergency and the stay-at-home mandate, this patient was seen because they're diabetic and they have a wound, because they're high risk for certain issues. We absolutely were not seeing any diabetic, quote unquote, at-risk care at that point, unless that patient had some other, extenuating circumstance that we had to bring them in. But we were putting that into our notes and charts. As far as telehealth, there are 3 particular areas that I would make note of why we're using telehealth. So one would be in the HPI, that the patient requested a telehealth visit because of a stay-at-home mandate in my state. What their issue was, a very detailed, back to podiatry school, NL-DOCAT type of HPI. The more information, the better, what they tried, what they didn't, how long it's been there. In our physical exam, I would solely document a visual exam if I could see it, meaning the patient would turn their computer around, I would look at their foot as well as their entire house and try to figure out what their foot issue was. I really would not document any physical exam besides visual, and I put it in there even for my own edification. In the assessment and plan, I would also, like Dr. Freedman mentioned the type of telehealth system we were using, if it was HIPAA secure video conferencing, what state, what town the person was in, what town I was in, and then also a blurb about how much time was spent with that patient via telehealth. And that was easy to do because the system we used was, notating the amount of time that the call went on for. So it's pretty simple to do. One of the other things we did in order to ensure that patients got their information that they needed from these telehealth visits was to use our practice uses a HIPAA compliant email suite. We use Google, but also Microsoft 365 is also HIPAA compliant. and our is our business name. So it is a safe way to communicate with your patient and send stretching, icing information, whatever information you want to send them. It's a good way to send those documents to the patient. It was absolutely imperative to reorient our staff to the new documentation policies, the privacy confidentiality protocols, just to talk from start to finish of how a patient made a telehealth appointment. If they called the office, my staff would send them a secure email with the link, with the time, would request them to send a secure email back with their driver's license, insurance card, and we would do a virtual check-in prior to the call so that everything would be in the system prior to our telehealth appointment. A little different than what we would normally do, because patients would sit in the waiting room with a clipboard and new patient intake. But, you know, unfortunately, you have to either go with the change or, you know, sit back and wait for things to happen. We thankfully did have all access to our EMR because it was a cloud-based EMR. So we do get access to it at home on our work laptops. Next slide. So as far as patient selection and scheduling, you know, we really want to be mindful of the type of services that we can perform safely via telehealth versus in person. I personally do not think that wound care or any sort of, you know, manipulation or invasive procedure can be performed through telehealth. It's virtually impossible. I think we were using, or we currently use telehealth more as almost like a triage. So if it is a patient who has a concern for an infection, we will absolutely take a look via telehealth for their, you know, for their safety. If we feel like they need to come in, then they come in either the next day, the same day. Again, if they're coming in the same day, we're not billing that telehealth appointment. It is really just a way to stay relevant in a time where people don't know that you're available. We are absolutely making sure that our high-risk patients know what they should be coming in for, when they should be coming in, and that they should really consider rescheduling their appointments. Early on in the pandemic, I cannot tell you how many of our older high-risk patients wanted to come in, maybe not realizing the severity of COVID or transmission, or, you know, how poorly our older population was doing with this virus. But our staff had to pretty much mandate that we were not seeing anyone over the age of 72 unless it was some sort of emergency, particularly diabetics or anyone with any other high-risk conditions that are listed on the CDC website. We absolutely had to establish patient screening processes for COVID, including asking if they were exposed to anyone with COVID, if they've had a fever, if they've had a cough, and also mandating that a patient, you know, wear a face covering. One of the questions that had come in before is, what if a patient doesn't want to wear a face covering? It can't be seen. You know, we reserve the right to refuse care for a short duration of time unless that patient wants to comply with the mandates that are in place, you know, not only by our office, but our state government. Face masks are mandated throughout the state of New Jersey. I'm not, you know, that may change in other areas and during different times of this pandemic, but we are absolutely saying no, one, for the safety of our staff, the safety of our doctors, but also anybody else in the office. There's really no reason to make any qualms about it. Now, patients may say that they're unable to wear a mask because of an ongoing respiratory issue. At that point, they can be offered a face shield, and also putting them on last appointment of the day to really minimize any risk of contamination of other patients or other areas in your office. In our particular area in New Jersey, many of our patients were hospitalized and discharged with COVID-related issues. Unfortunately, many of our patients did succumb to the disease. So we absolutely want to review any recent hospitalizations, anything that was out of the ordinary in the last 3 months. You absolutely want to talk to your patients about this, especially if you're in an area like mine. And I am going to turn it over to Linda McSmith.
Hi there. Thank you, Dr. Patel. I get the drier subjects of the evening, I think, a little bit. First, we're going to start out addressing federal and local considerations. use your state and local government offices for guidance. Every state has different guidance, and you can call from county to county and even get different advice that way. So if there's a situation that presents for you, the first thing you should do, especially if it relates to somebody that's positive and how to relate to that, is to contact your local office and ask for suggestions and recommendations. Dr. Freedman, did you want to add something there also?
No, I just think the most important thing is always looking at that, and CDC guidelines is the biggest thing that we've been following as what's important for this during this time.
Absolutely. And you have to realize you have a duty to utilize universal precautions. Notwithstanding the current crisis, this is something that you always have to consider and utilize. And these are put into place to prevent any cross-contamination of any type of infection or communicable disease. To that extent, you need to make sure that you understand what those guidelines are and be able to educate your staff so that they feel better interacting with the patients, and also educating them on how to utilize their personal protective equipment. There are CDC guidelines, some are on their website, which there are links on both the APMA and PICA websites for COVID related to the infection control basics, isolation precautions, respiratory hygiene, and cough etiquette. Remind your staff what those things are. Make sure that they are feeling comfortable. I did see a question come in just recently about the staff not being comfortable with having COVID patients possibly in the office and or having more than one patient in the office at a time. Ultimately, this is your practice's decision on how you want to handle that, whether or not how you're going to segregate and allow for incoming, outgoing, so that they're not cross contaminating each other or anybody else in the office. And the biggest thing is to educate the staff. I think if they know more about what they're doing and the information that's available and what to do correctly, they will have a better idea of what to do. So when it comes to the OSHA guidelines, we have to consider that, you know, this is a current crisis, and universal precautions and standard precautions are always the best thing to use. So think about bloodborne pathogens, protective equipment, and respiratory protection. We also have a recent webinar that's put out on the website. Anybody can utilize that, whether you're a PICA insured or not, on bloodborne pathogens. So feel free to go out, listen to that, and it has a little bit more of a tone towards COVID-19 and the pandemic, but utilize that also for your staff as a way to educate them. OSHA's clause related to what you have to do states that you're required as an employee to protect your employees against recognized hazards. And at this point in time, COVID-19 would be considered a recognized hazard. So you have a duty to keep them safe and protect them as well. So if a patient comes in and refuses to wear a mask and they don't have a legitimate type of situation or condition that would require that it would be contraindicated for them to wear one, and that you then deal with that, as Dr. Patel alluded to, in the scheduling of that patient, then if it's the policy and the direction of your state and local government that they wear a mask, then you need to explain that to them. And then if they decide they're not going to come for their appointment, you can suggest that if they need to be seen now or urgently, that they go to a local ER or urgent care facility. Chances are they're going to be asked and required to put a mask on there. But you have a right and the requirement to protect yourself, your staff, and the other patients. So when you're looking at some of the different things, you need to look for credible resources, and those are the CDC, OSHA, WHO. There are a lot of things out there and a lot of links, so avail yourself of them. A lot of it is just becoming educated yourself on the information so you can impart that correctly to your staff and patients in communications. Review what's happening within the cleaning of the environment, whether it's in between patients cleaning that room down, or whether it's your vendor contract. What does the contract say? What are they using as far as protective equipment? What type of additional education might they need on bloodborne pathogens, that they're just a cleaning company that just comes in to clean the office and they do not know anything about healthcare? So think about that as you are looking over those contracts and looking at them. Also, the CDC has a great return to work guidelines that have been provided. And then again today, CMS put out a new recommendation about reopening facilities to provide non-urgent, non-COVID-19 healthcare. And so that will be, I believe, added to our website tomorrow. And that's additional information that is great to provide you with some guidance and some education for your staff. Now, when you're looking at the staff returning to work, they're all going to have different times and places in their current status as to returning. If they have health conditions that would preclude them till later returning to work, that needs to be considered, as well as the kind of things related to health, childcare, and people returning. Think about how you're going to monitor them and put into place what needs to be done. I know currently a lot of large companies and corporations have really worked to put together a very detailed plan of return to work process. So that's always important to think about. Maybe not everybody has to return in the initial phase. So who can come in initially, and then are you going to screen them? And you should screen them daily, both with temperature, make sure that there's been no changes in their conditions, and then move forward from there as well. Also, think about the social distancing in the office. Think about where people tend to congregate. Are there computers in certain areas? Do you need to separate those a little bit? What about lunch? I know some offices require that they may close for a certain period of time and there's no eating in the office. So you want to think about how you're going to handle that, and making sure, as everybody has already talked about, how you're going to bring patients through the office into different areas to address keeping them segregated. Once again, infection control protocols with the staff, I can't emphasize that enough. We're always looking to make sure they understand what they're doing and why they're doing it. They'll be more compliant if they know why. So monitor them. Are they doing and following the directions on the cleaning solutions that you're utilizing that are your virucidals? Make sure you have sufficient supplies. I know a lot of people are still looking for vendors to get masks and PPE equipment. I believe there's been more opening in the marketplace related to that. I did see a question come in this evening also. I don't have a specific vendor to point you to, but I believe we may have something that I can get back to you afterwards about, unless Dr. Patel, you might also have some information about that.
Yeah, one of the things I mentioned during one of our calls, town hall calls a couple of weeks ago, was that Amazon is allowing healthcare providers to order PPE for their offices first. You have to have an Amazon business account. They'll verify that you're actually a healthcare office, and then you can buy anything from KN95s to sanitizer to pretty much anything you would need.
Great. Also look at the different areas within your building itself. Look at the refrigerators where you store medications and testing supplies. Make sure that there's no outdated medications. Make sure that the temperatures are staying consistent and you haven't had any issues related to that. I'll kind of go into some other little tips when we talk about the building as well. Additionally, we talked about the areas, minimize waiting areas. Dr. Patel had a great idea of not even having the chairs in the waiting area. I've been to a few offices with the notices on all the chairs of where you can sit and not sit, but I ended up in an office at the end of the day this week, and oddly enough, most of all those signs have been moved and all put in one chair, and it's all just rearranged. So think about how you can monitor and make sure that you're not putting people at risk in the waiting room, and limit those visitors, and screen your staff regularly and also your patients, and think about what you're going to do with those logs. So keep those logs. If you're having the patient complete an attestation, include that into your medical record. And an attestation is kind of an acknowledgement that COVID is going on, and what they are reporting, that they are not yet in contact with anybody known and their symptoms, but you're doing the best you can as well. But there's no way to eliminate a potential chance that somebody might contract the COVID-19 virus, whether you know it happened at your place or it could have happened at anywhere possible. Supplies, we were talking about the PPEs. Make sure that you have a sufficient amount of supplies if you're seeing patients. Make sure that your staff have been provided those. Somebody had asked if you're required to provide those for staff, and yes, you would be. Verify that your equipment inspections are up to date. Sometimes that's a good thing to have staff do if there's some slow periods where you don't have patients. Utilize them to double check expirations on drugs, expirations on equipment checks, and look for all out dates. Also, check your autoclaves that you're running and make sure that they're running proficiently and are remaining intact, and that the instruments that you previously have run have not expired and remain intact and undamaged. The building and systems. I would recommend that you run tests on your fire and security alarms. A lot of times when you've been out of the building for periods of time, that's always a good thing to do. Make sure your exit signs are lit, that your smoke detectors are active. You could even ask your company to come in and do a walkthrough to make sure that those systems are all in place. Also look at other engineering controls that you can put into place. There's nothing that's been mandated at this point in time, but you can consider plexiglass barriers. Some are doing that within the check-in, check-out areas. Some are doing that on their computer stands that they utilize in the room. I've also seen all kinds of situations and information that's been out there. Some have created a plexiglass barrier if you're working on the feet that goes between the doctor and the patient, that kind of fits over the area there on the table. So it's really up to you and some of the things that you do. Some of the other things to think about are touchless faucets. Those are a little bit more tricky to try and put in at this point in time, but the touchless soap dispensers or paper towel dispensers. Also think how those things are utilized, where you have them, opening doors so that people don't have to touch the handles all the time. Or once that room is cleaned and ready for that next individual, having that door open so you don't have to touch those handles as much as well. And so from that, I think we're going to open up for questions next.
Thank you, Dr. Freedman, Dr. Patel, and Ms. McSmith for all of your information. We do have time for questions, so if you do have questions, you can use the Q&A toolbar to let us know what your questions are. But I think we have a few that were sent in advance that we could still address. Could you all comment on whether or not patients should sign a waiver on the possibility of getting COVID-19 despite any prevention implementations that have been done in the office?
You take that one first, or are you going to do that, Krupa?
I'll take it. I'll take it. We actually use the waiver or the consent to treat that was posted on the PICA website. I think it's really just for our own edification. I think patients, especially in our area, know that they can be affected with COVID from the grocery store to my office to anywhere. But we do use the waiver that's on the website.
And we kind of use a screening form that every patient signs when they come into the office. So we're asking them specific questions or answering the questions. And if there's anything that is any potential issue, we're not letting them even in the door. So we're trying to prevent that potential patient from being in the office. So all you can do is do your best. And I think that's the best thing I can say at this point.
Great, thank you. Can you clarify if there's anything practitioners can do legally if patients refuse to comply with wearing a mask or following posted policies or protocols?
From the doctor standpoint, I mean, we should all be wearing masks. We should all be protecting ourselves if the patient doesn't want to wear one. And the mandate in your county, in your state, is that everyone's wearing one, then that's the protocol that you're using. You can refuse someone the care as long as there's no emergency care that has to be rendered, or you can refer them to somewhere else to be treated if they aren't willing to comply with your request. So I don't think you have to, if someone says they refuse to wear a mask, then in your policies, everyone wears a mask, everyone wears a mask. It's just, that's what it's got to be. I'm sure Dr. Patel probably agrees with that.
100%. Mm-hmm.
And I would add in there, if a patient is objecting to it or staff are uncomfortable with patients in the office, then it's the practice and the leadership of the practice that need to stand it up and address those issues. Nobody can tell you that you have to make somebody do something, but you as the leader of that practice need to consider how you are communicating with your staff so that they feel comfortable being there and working on a daily basis as well.
One of our colleagues asked, do I need a COVID test and does the patient need to be tested before a procedure?
In our area, if you're doing elective surgery that requires IV sedation or general anesthesia, the hospital, ASC, you do have to be COVID tested before you have that procedure, because obviously the anesthesia provider is at risk more than anyone because they're working over the head of the patient. So what most are doing here, at least in our area, is they're asking them to do COVID testing as a screening tool. Doesn't mean they have COVID, but they're doing it as a screening tool at least 48 hours to 72 hours before is the mandate. And obviously then the person has to technically quarantine themselves right after that test, because they could get exposed by someone else that has COVID if they go to the grocery store or somewhere else after the test. So then the test becomes totally worthless to the provider. So they have to pretty much almost attest that they didn't go anywhere, because then that sets them up for potentially being exposed to someone that could have had COVID in the community. So that's pretty much the protocol currently. If it's a local case, I don't see how that would be necessary to do COVID testing if you're doing like an ingrown toenail procedure in your office and they have no signs or symptoms of COVID. I don't see how and why that would be necessary, but I could see doing it at an ambulatory center, hospital, that type of thing, and I'll let Dr. Patel answer as well.
Yeah, in our area, any elective procedure, any procedure at an ASC or hospital, you have to be COVID tested, not the doctor, but the patient, within 96 hours of the procedure. They are not requiring doctors to be tested, but we are urged to self-monitor. So daily temperature checks, if not twice daily temperature checks. And then obviously using your due diligence to know that if you are feeling any symptoms, you are going to go get tested and make sure you're not exposing your patients.
Great, thank you. Can you talk about any specific or unique risks due to the podiatric profession for airborne particles and nails, trimming of nails, debridement of nails?
So, last I heard, I don't think we breathe through our toenails. Yes, I mean, theoretically, anything that you cut, grind, whatever can be aerosol, but that theoretically would not most likely have the infection in it. So from that standpoint, from where we're working, what we're touching, what we're doing is most likely not going to be contaminated with the COVID virus in most cases. So you can't say everything's 100%, but that certainly seems to be what's currently the thought process.
And can you talk a little bit about what you would do in your practices if an employee gets sick with COVID? What steps would you take?
Do you want me to take that, Dr. Freedman?
Take it, sure.
So in our practice, we put together a COVID protocol, which is a policy for all the employees to know what to do if they got sick. Not only that, but also what to do around the office, how things have sort of changed post-COVID. So every employee is being temperature checked. So we're not waiting for them to be positive with COVID. If they have a fever over 100 degrees Fahrenheit, they're either going to go get COVID tested or they're going to be home for 10 days. That's a CDC recommendation on a return to work for healthcare workers. And that's what we're following. So we actually had that instance the first day I brought someone back. The next day she had a fever and she stayed home for 10 days. In our area, COVID testing, we have it everywhere pretty much, and it's free. One of the things I did do in the office is actually print out locations, not only for my staff, but also for patients who, you know, during this pandemic, when there was a lot of talk about COVID toes and, you know, those sorts of vascular changes to digits, we had a lot of patients doing telehealth or even in-person visits thinking that that was what was going on. So it just made our life easier just to print out locations in our area for patients to get free COVID testing. So 10 days minimal.
And also think about cleaning the rooms, making sure everything is not terminally clean like in an OR, but cleaning all those surfaces in the rooms to make sure everything's taken care of as well.
Is there any way to force insurances to reimburse for the significant increase in overhead due to PPE?
Only wish it could. I think you find that the dental community's already started charging fees for their expenses. It's not typically being done with medical doctors, podiatric physicians that I've seen, but I've seen dentists already starting to do that because they had to invest significantly in equipment for sterilizing and cleaning their offices that we haven't had to do to the same level. So right now I can say you really shouldn't do it ethically, in my opinion. And I don't think it's something that I would want to do.
Great. How can I be protected from lawsuits related to coronavirus?
I would say, first of all, do what you're supposed to do. Universal precautions, educate the patient, get those consents / attestations. Also, encourage them, if their condition changes, to contact the office. If anything happens as it would relate to a patient bringing about allegations that they got it at the office, that would be looked at on its individual basis. We can't look at it from a hypothetical situation as a carrier, but if you've done everything that you're supposed to do and you've practiced medicine and you're within your scope of practice, your policy, you would submit that claim and we would work with you through that process from that standpoint.
Great, thank you. Is this the new face of medicine or is this just temporary?
I hope it's temporary.
The $1 million question.
Like everything else, everything goes in phases. So this is a phase. It's just we're living through the phase right now, but there'll be something else 5 years from now, 10 years from now. But right now, this is what it is, and you do your best to make lemonade out of your lemons, right?
And with the opening of a lot of states with different stages, we may very well see an uptick and another whole wave of it come about again before the end of the year.
The next question is a telemedicine question, and it is, can you talk about the authorization requirements or documentation that you might have before a phone or telemedicine visit?
Well, there's two options when it comes to the authorization. PICA has provided a great authorization that's written that you can provide to the patient. You can mail it to them in advance, fax it to them, email it, however you want to get it to them through your portal, and get them the authorization that way. You can also have a verbal consent and authorization as part of your telehealth visit that you clearly delineate that you offered them this, that they agreed to do the telehealth visit, and that it's doing the public health emergency, that it was mandated that this was an option. They chose that option. And then obviously that anything that's more emergent or whatever, they would have to be seen in the office. So you can easily do telehealth. It's just a matter of just doing the right things to keep yourself and your head above water.
Dr. Freedman, are you getting insurance authorization for telehealth? Because I know we're not. We're just setting it because we don't need to, right?
The experience that we've had, because we deal with so many states, is that the only one we're having a problem with is some state Medicaids, because in certain states, podiatry is considered it's not mandated, and therefore podiatry can be excluded, and they would exclude you from being the physician, even though they said that they would allow physicians to provide telehealth. So as far as I've seen with the big payers, you know, the Blues, the Aetnas, the Cignas, the UHCs, whatever, Medicare, obviously, they're paying for telehealth. And if you go to their websites, you'll see that they are offering that. You just got to carefully use the correct modifier that goes along with the telehealth, because each payer has different rules. And there's actually up to about 4 different modifiers that can be used depending on the insurance company. The most common one is modifier 95, but there's also GT, I think there's GC, there's CR, there's GQ. It just depends on which insurance company and which alphabet they want to use that for their policy to get telehealth paid. The best part is we've been able to use E&M visits that we normally bill for in the office. So you're getting paid for your typical office visit at the same rate, even though you're doing it at telehealth during the emergency. So that's also been a positive that they allowed that to happen.
I would add that I believe the APMA has a really good webinar out there related to telehealth and the coding of it. And we have also done one that's posted on our website as well.
Thank you. So I think we have time for just one more question before we close out this evening. Can you talk about whether or not gloves are recommended to wear routinely in the office by the staff?
We don't mandate that. We mandate that they wash their hands, or they use some type of 75% alcohol or higher content Purell, whatever the content is, to keep washing their hands between patients, between touching things, wiping down surfaces. If they wear gloves, the problem with gloves, people think that's like a great secure thing, but when they touch something and they go touch something else, they're now bringing that contaminant with them wherever they're going, and they think that they're just keeping everything clean, but they're not. They're moving bugs around the room and germs around the room, which I don't want them doing. So I'm sure Dr. Patel, you feel the same way?
Agreed. Yeah, we're discouraging the use of gloves and just really making sure people are washing their hands and using our hand sanitizers. One of the other things we've done is also minimize patient contact with our staff. So our medical assistants aren't doing the functions that they were, whereas, taking vitals or rooming patients or bringing in tools or assisting. It's really just to limit the contact of the medical assistant and the patient as well, but absolutely not to gloves.
Great, thank you. I want to thank our panelists and you all for joining us for this evening's webinar. You can find additional information related to COVID-19 on both APMA and PICA web pages. The addresses are listed at the bottom of the screen. And I just want to remind you that this webinar is not for continuing education credit hours and cannot be used for a risk management discount. But again, I want to thank you all for joining us this evening, and I hope you have a great night.